Thank you for joining us, everybody. Welcome to the Dermatology Update in partnership with St George Hospital. My name is Bertha Harvey and I'm the CPD and Events Manager at Central and Eastern Sydney PHN. I would like to start tonight by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise the continuing connection to land, water and community and pay respects to elders past, present and emerging. I also extend that respect to any Aboriginal colleagues who may be joining us tonight. So I would like to introduce Kylie Turner, who is a chronic kidney disease CNC and a member of the St George Hospital Integrated Care Chronic Disease Working Party. Thanks, Kylie.
So my name's Kylie Turner. I'm actually the chronic kidney disease CNC at St George, but I also chair the St George Hospital Integrated Care Chronic Diseases Working Party. And we have developed this GP education program in partnership with the PHN. And the idea behind our Chronic Disease Working Party is to try and connect better the tertiary hospital with the general practice. And a couple of the areas that we have focused on up until now have been the discharge summary, helping the general practice to navigate tertiary institutions, and then just basically improving the care given to chronic disease patients within South Eastern Sydney Local Health District. So I'll let Dr Rivero talk from here.
Thank you so much, Kylie, for the introduction. Good evening, everyone. My name is Alexis, and basically these are the learning outcomes for the session that we're going to talk about tonight. Have to discuss my conflict of interest, as you can see on this slide. We're going to have a bit of a chat regarding atopic dermatitis and the newer treatments and how GPs can help us in terms of managing and monitoring these patients with this condition, and that you're also having these kind of treatments. I would like to start with just briefly mentioning this part in terms of epidemiology. I just want to show you these figures. Perhaps the most important things is that number one or 2% of the adult population might present it, but 50 to 20% of the children actually can have it. And this definitely can cause a huge impact in the quality of life of the patients affected by atopic dermatitis. But interestingly, most of them are managed with topical corticosteroids. Oral corticosteroids have been used, and we're going to talk about that later on. But interestingly, there are some alternatives in terms of treatments, immunosuppressing agents, either oral or topical, that are barely used and should be using more in terms of improving the patient's symptoms and disease control. There are other features of atopy that are actually useful to always check on, like hay fever or asthma, that might support the diagnosis of eczema in our patients. And this is a condition that actually makes the patients to spend a lot of money, as you can see there, just trying to be compliant with skincare measures. Just to mention briefly that atopic dermatitis is a complex skin disease where you have a genetic predisposition to skin barrier dysfunction, that there are multiple triggers that can be external, like microorganisms or irritant or sensitizing agents, but also sometimes that can be related to food allergies, including the dysregulation of the immune system with a predominantly Th2 response. That is actually one of the bases for the newer treatments for eczema, and the dysfunction of the neuroimmunologic pathway that is usually associated with the itch, that is one of the cardinal symptoms of this condition. You can remember very well, we have three stages, or actually three categories of eczema: the acute, the subacute, and the chronic. Each of one can pose several differential diagnoses, but perhaps the most challenging ones are the chronic ones, because the changes sometimes can look like psoriasis, and occasionally this condition can be confused with psoriasis. But ironically, in the past, we thought that eczema and psoriasis could not coexist. But nowadays, we know that that's not the case from both the pathophysiology point of view, but also patients that we have seen that they have overlapping conditions. The triggers, as you might well know as well: weather changes, irritants, infections, particularly bacterial infections, staph or strep, herpes simplex, molluscum, and perhaps something that I might throw here, particularly in children. If you see a child with unilateral eczema, it's quite likely that it might be a reaction to molluscum on the eyelids. Just keep that in mind. And also environmental allergens, like particularly pollen, dust, mold, and fragrances can be triggers for atopic eczema. and food allergies, as you can see there. But keep in mind that a positive result doesn't necessarily mean that that's the cause of the problem. So this is important to have a proper discussion with the patient regarding the results to see if there is a correlation between the exposure, the positive result, that they might confirm that this can be the trigger for the, or one of the triggers for the eczema. The differential diagnosis, as you might see there, other forms of eczema that are non-atopic related, like seborrheic dermatitis, contact dermatitis, either irritant or allergic, dry eczema that is actually quite common in seniors, stasis dermatitis related to venous insufficiency, and vesicular eczema on the hands and the feet, infections like impetigo, herpes, tinea, and scabies, other inflammatory conditions, psoriasis, lupus, lichen planus, drug reactions, and sometimes medications can also cause eczematous reactions like statins, thiazides, and calcium channel blockers, for example, and certain neoplasias, particularly when you have a single lesion or lesions in an asymmetric distribution, could also help you think that this might be a potential differential diagnosis. Just very briefly going through the basics in terms of treatment, because this is also very paramount in terms of optimal management and care for our atopic dermatitis patients. So as I mentioned before in the pathophysiology, we need to address basically three areas, that is the barrier dysfunction, the itch, and the inflammation, and to try to avoid, if possible, or to reduce the triggering factors, manage any associated conditions or comorbidities. And sometimes there are multiple resources available online that we can provide to our patients in terms of general skincare management, or to prepare things like, for example, the bleach baths. With the basics, short showers with lukewarm water, using a mild cleanser, ideally soap-free, emollients daily after the bath or having a shower, particularly addressing the skin barrier dysfunction. And sometimes bleach baths are recommended. There is a formula there that you can see and you can use. You could add on, like, for example, oil or salt, because interestingly, you might see some patients sometimes when they actually swim in the ocean and they notice that the eczema gets better. And interestingly, can be related to the natural physiological or natural the effects of the salt on the skin. Just be careful if you're using the chlorine, that sometimes asthmatic patients can have a little bit of flares when it's exposed to the irritant effect of the chlorine fumes. Although in bleach baths, it's very less likely to happen compared to, for example, swimming in the pool, that sometimes patients can ask us as an alternative for a bleach bath. And we can use wet wraps just with the moisturizers or with the topical corticosteroids, either at home, or if the case is very extensive or severe, or if it's difficult to do that at home, sometimes we can do it as an inpatient in the hospital. The treatment options that we always start with the topicals, precisely addressing the itch and the inflammation. The most common agents, the topical corticosteroids, but I like to always mention medications like tacrolimus and pimecrolimus that are really useful, and I'm going to talk about them a little bit later on, and a newer agent called crisaborole. But in severe eczema or eczema not responding to topicals, we need to consider other agents like the standard immunosuppressive agents, as you might see there, to try to avoid the oral corticosteroid as possible. We can use it as an emergency treatment, like, for example, for a bad acute flare. But if we start to notice that the patient requires to use it often or for long periods of time, it means that it's becoming dependent, and the problem is the rebound dermatitis that we can see when the effect of the oral prednisone grows off. And that's when the newer agents come, like these ones, like Dupilumab or upadacitinib, that are available on the PBS if the patient fulfills certain criteria that we're going to mention later on in the talk. And also, there is the possibility of have access to newer agents that are on the trials, and some patients that might not be candidates or might not qualify from the PBS criteria, but the eczema is considerably disrupting the quality of life, could be potential candidates for these trials. And sometimes we also use non-medication options, such as phototherapy, available at the St. George Hospital, by the way. And apart from these, we can combine agents for symptomatic management of the itch, that is usually one of the most preponderant symptoms and the most annoying symptom for atopic dermatitis, such as antihistamines with sedating effects, or tricyclic antidepressants such as amitriptyline or doxepin. Going with topical corticosteroids is something that we can use once or twice daily and with an appropriate strength. It varies depending on the site, the vehicle, and the occlusion. Just keep in mind that if you're using richer formulas, it increases the penetration, so it's more effective, but you need to be more careful about side effects. For example, if you are using strong corticosteroids on the face, the folds, or the genital areas, as I'm mentioning there. It is important to also explain to the patients that the clinical clearance doesn't necessarily mean that inflammation underneath the skin or within the skin has been fully controlled. And that's why the concept of treating the subclinical inflammation, is important in terms of deciding for how long the patient needs to be on the treatment. As you can see on the right side of the slide, for how long on the active phase, you should use it daily for up to 4 weeks. And interestingly, that's one of the criteria of PBS for the patients to have access to the newer treatments for eczema. And then in the maintenance phase, one that is complete clearance or marked improvement of the inflammation, we can either reduce the strength or the application of the topical corticosteroids, or we can transition to a non-corticosteroid option, such as tacrolimus, pimecrolimus, or crisaborole, as I mentioned before. And it's important to address the steroid phobia that's actually becoming more preponderant, unfortunately, due to the effect of the media and the sources that sometimes patients can look information from. Because I might just throw a quick comment here. There was a study actually performed here in Australia where they compared 2 groups of patients. One group actually was using the corticosteroids for flares as required, and the other group used the corticosteroids pretty similar to the scheme that I'm recommending here. And then what they do is actually quantify the total amount of topical corticosteroids that they used after a year of monitoring. And interestingly, or not unsurprisingly, they discovered that the patients that they were using it only for flares ended up using bigger amounts of corticosteroids compared to the patients that did the treatment properly to try to control the subclinical inflammation. This is one of the options that is very useful, but unfortunately underutilized for 2 reasons that we're going to mention in a moment. Tacrolimus and pimecrolimus can be used once daily or twice daily. The tacrolimus is only available in Australia through compounding. So we use lower concentration for pediatric patients or areas of sensitive skin, such as the face or the genitals, and the higher concentration in adult patients or patients that can tolerate lower concentrations with no issues. But we also have a standard formula for pimecrolimus that is available on the regular script. They can cause a little bit of local irritation. So perhaps particularly pimecrolimus, because the cream has a little bit of alcohols in the formula. So that usually can cause a little bit of the stinging or the burning sensation when they apply it onto the skin. So we recommend, perhaps if that's the case, to apply a thin layer of moisturizer first and then apply the topical calcineurin inhibitor on top. And that's actually really useful to reduce that local stinging or burning sensation. They also did safety studies for people that applied this medication on the same areas of the skin daily for up to 1 year. It was actually an American study in pediatric patients with atopic dermatitis. And after they did a follow-up for more than 10 years, there were no increased risk of infections or malignancies. So this is actually really reassuring. And perhaps one of the most important things, especially for you guys, when to refer the patient or when to get dermatology advice. If the eczema is severe, affecting more than 30% of the area, either the body or particularly the face or the hands, that's one of the reasons. And especially in a patient that is completely red from head to toe. If there is, if more on the moderate eczema category, but there are potential overuse or side effects of the topical corticosteroids, for example, using it daily for long periods of times, rebound dermatitis, or features like, for example, atrophy or telangiectasia, and the patient is unable to tolerate or to switch satisfactorily to a different topical, definitely another reason for the specialist review. If you think that there might be issues with treatment compliance, if the eczema is impacting considerably the well-being and the mental health of the patient, if you are sure that you are explaining it properly, patients are doing properly general skincare measures and general eczema management, if there is recurrent or chronic use of oral prednisone, that is a big reason for dermatology review. And when there are possible or multiple differential diagnoses, and you might not be fully confident to get a clear diagnosis on clinical grounds, definitely we are more than happy to help you with your patient. And I wanted to put here precisely the criteria for PBS for eczema patients to have access to either Dupilumab or Upadacitinib, that are the two newer agents that we use for severe atopic dermatitis. If we're talking about the body, this is a score of severity that should be more than 20. So perhaps going back to what I mentioned before, if you think that roughly more than 30% of the body surface is affected, definitely that could be potentially a severe score. Or if it's affecting the face more than 30% or affecting the hands more than 30%. We also perform at the moment of the review this score that is a dermatology quality of life index. And also the bottom line, that is one of the main criteria under PBS, and that's why I spend a little bit of time talking about the topicals, is because the patient should have failed either the topical corticosteroid or the topical calcineurin inhibitor daily for 4 weeks. Okay. Briefly talking about these two new medications. Dupilumab is a monoclonal antibody, therefore is an injection that is approved for TGA, approved for atopic eczema, asthma, and chronic rhinosinusitis with polyposis, but is currently covered under PBS for atopic eczema and asthma, not for nasal disease yet. The efficacy and safety has been demonstrated in multiple studies that I don't need to show for the purposes of this talk. Definitely reduces the itch, reduces the impairment in the quality of life, and improves the scores in terms of eczema severity. We do a loading dose, 600 milligrams subcutaneous injections. Actually, the vials are 300 milligrams. In pediatric population, is lower, is 200 milligrams the dose. So we do the double dose at the beginning, and then we do one injection every 2 weeks. There are no significant pharmacological interactions, and this is something that we explain to the patients, but it's also important because from time to time they might ask you guys, can I stop the treatment? So far, we recommend this as an ongoing treatment. In terms of side effects, injection side reactions, and perhaps the two more common side effects when we're treating eczema, when we're using Dupilumab for eczema, is the injection side reactions, the facial redness and the blepharoconjunctivitis, which means that sometimes we dermatologists need to intervene in terms of other treatment options that we can use to try to manage this problem. Other problems like eosinophilic disorders, more in patients that have been using it for asthma rather than eczema. There is no overall increased risk of infections while on Dupilumab, which doesn't necessarily mean that they cannot occur, because eczema patients as such are an increased risk of skin infections. There is a theoretical risk of parasitic infections, although the risk is unknown so far. And as any medications, there are cases of hypersensitivity reactions, but these are actually really rare. So one of the advantages of Dupilumab is that it's not formally required to perform investigations prior to starting the treatment. However, we do them because we want to assess, for example, if there is peripheral eosinophilia and if we need to investigate other causes of eosinophilia and skin manifestations. During the treatment, also, there is no need for monitoring with blood tests. We usually monitor the patient on clinical grounds. However, because of ongoing data surveillance, some specialists might like to perform safety bloods, as you can see there, full blood count, ESR, CRP, UECs, LFTs, and we do it every time that we do the safety review for the patient. Regarding pregnancy and lactation, this is considered category B1. However, there is still insufficient data, and the recommendation is to weigh the risks and the benefits of this treatment on a case-to-case basis. There is no specific data regarding lactation, but because IgG can can be found on the breast milk, is not recommended during breastfeeding because the risks for the baby at this point are still unknown. In terms of vaccinations, that is something that's really useful for you guys to help us in that regard, because it's currently recommended to update with vaccinations prior to starting the treatment. If live vaccines are required, there is a minimum of 4 weeks as a matter of safety after the last dose of the live vaccine prior to starting the Dupilumab treatment. And if the patient is already on the treatment and a live vaccine is required, there is still a bit of a gray zone in that regard. But it is said by some experts to actually stop the treatment for 12 weeks and then administer the live vaccines. But if it's a non-live vaccine, no problems at all. And also there is no reduction of efficacy on patients on Dupilumab that might require non-live vaccines. It has been done, like, for example, with pneumococcal and DPT vaccinations. Regarding perioperative conditions, if needed, some specialists recommend to stop the treatment 2 weeks prior to surgery. Others are a little bit more extreme and use the similar 12 weeks prior. Also, this is decided on individual basis because there is not much experience yet in that regard. And but however, some specialists, particularly if the patient has had severe eczema, to avoid eczema flares that might complicate certain surgeries, they recommend to continue the treatment to avoid flares with superimposed infections that can actually be the problem for the patient, especially in terms of wound healing. Moving on now to the oral agent, that is upadacitinib, that is a selective JAK1 inhibitor, is currently approved, TGA approved for rheumatoid arthritis, ankylosing spondylitis, axial spondyloarthritis, psoriatic arthritis, ulcerative colitis, and atopic eczema. And its PBS covered for all these indications except for ulcerative colitis. Likewise, as Dupilumab, the efficacy and safety demonstrated in multiple studies. The dose varies between 15 to 30 milligrams once a day. We need to remember in this case that yes, there are some interactions. The levels of these medication can be increased when co-administered with 3,4-A inhibitors such as itraconazole that perhaps we might use, for example, if we need to treat fingernail or toenail fungal infections. Clarithromycin and more than half a liter of grape juice a day. And the levels can be decreased when co-administered with phenytoin and rifampicin, and this is also an ongoing treatment. Side effects, we actually are a bit more careful with this one because of the more stronger immunosuppressive effect. Definitely serious infections have been reported, and I actually had a couple of patients, unfortunately, that had them, but with no serious or life-threatening reactions. That can be either bacterial, mycobacterial, and viral, especially viral. There are reports of reactivation of hepatitis B, herpes simplex, and shingles or herpes zoster. In terms of thrombotic and thromboembolic events, this has been reported in the trials for rheumatoid arthritis, but for the atopic dermatitis trials, it was not reported a single case, but it can be a potential risk that we specialists need to discuss with the patients. And also extrapolated from tofacitinib from patients with rheumatoid arthritis, a potential risk of increased risk of malignancies such as non-melanoma skin cancers. From the skin point of view, we can also see reactions like acne or folliculitis. Bowel perforations were not reported in eczema trials, and there also the possibility of hypersensitivity reactions. And in terms of changes in the bloods, that's part of the monitoring that we're going to talk about later on. We can see a bit of anemia, neutropenia, or lymphopenia, derangement of the liver function tests, elevated cholesterol and triglycerides, and it's also elevation of the muscle enzyme, the CK, but so far it's of unknown clinical significance. So how do we screen the patient? Before starting the treatment, we ensure that we have done the proper cancer screening appropriate for the age and the gender of the patient, because most of the eczema patients are actually relatively younger. Probably this doesn't have to be that thorough. We do the bloods, as you can see there, full blood count, ESR, CRP, the metabolic part like BSL, lipid profile, kidney and liver function, a basal CK just to ensure that is normal before starting the treatment. We need to check that there is immunity against common infections such as measles, mumps, rubella, varicella, Hep A, Hep B, and also to check for serologies such as strongyloides, syphilis, HIV, hepatitis C, and quantiferon gold as part of the tuberculosis screening. During the treatment, especially in senior patients, we need to be sure that also the cardiovascular cardiovascular aspect of the patient is properly monitored. We do similar bloods as we did before. However, we don't routinely check for CK unless the patient is symptomatic, or if the patient is at risk or also having myopathies, like for example, being on a statin as well. And we do repeat malignancy screening when appropriate. Actually, there is no need to do it more often as per the guidelines. However, they recommend an increased frequency of skin examinations, such as full skin examination that we dermatologists can do when we're doing the assessment or the safety reviews for patients on this treatment. In terms of pregnancy, category D, so it's definitely not recommended, and also it's not recommended to be used while breastfeeding. Vaccinations for upadacitinib, likewise, we recommend to start them before starting treatment, especially regarding herpes zoster, if appropriate for the age of the patient, as I mentioned before. Also to wait a minimum of 4 weeks after having a live vaccine before starting the dose of or the treatment with upadacitinib. But because the half-life is far shorter, if the patient is already on the treatment and needs to stop it because they require a live vaccine, like for example, yellow fever, patients that are traveling overseas, it's only 1 week that the patient needs to be off the upadacitinib and then they can have the live vaccine. Likewise, there is no apparent reduction of the efficacy of non-live vaccine in patients on upadacitinib. And regarding perioperative management, it's recommended to stop it. The American school says 4 days, the European says 7 days. So perhaps as a matter of safety, we might go with the 7 days, stopping the treatment before the surgery, and we can restart it 2 weeks later, provided that the wound healing is well and there are no features of infection. So perhaps now in summary, and this is perhaps the things that I would like you to remember after all this talk. Atopic eczema is a quite common condition, as you very well know at GP level, that can impair significantly the quality of life. The general skincare measures are really important, and if we prescribe an appropriate course of topicals, including either corticosteroids, calcineurin inhibitors, or PDA inhibitors, that can be helpful in most of our cases, but we need to keep in mind the differentials. And the most important thing is to address the topical corticosteroid phobia properly. There is now this fancy term, the topical corticosteroids withdrawal, that actually started with a Japanese report in 1972, if I am not wrong. And finally, I managed to get a grasp of the article. And the thing was reported is in a baby with, I think it was an 8-month-old baby with widespread eczema, that they were using strong topical corticosteroids and actually had suppression of the adrenal axis. And when they tried to stop the topical corticosteroids, the baby did adrenal insufficiency, and the eczema rebounded really badly. So that's why they use the term of topical corticosteroid withdrawal. But that doesn't necessarily apply to what's happening in our current patients. We might know that there are changes in the environmental exposures, chemicals from the environment, pollen, preservatives, occupational exposures, epigenetic changes. So those things actually can exert an influence in terms of the behavior of eczema in our patients. But in patients that need to be potentially referred, keep in mind that there are systemic agents and phototherapy that still have their roles, because sometimes patients might have contraindications or the treatment might not be as effective as they were thinking. And in that case, we can consider the classical agents, for example. And that's why we have these PBS subsidized treatments that are really useful, such as upadacitinib and Dupilumab, but that are only prescribed by dermatologists. Dupilumab, remember, sometimes the patients can experience facial erythema and a little bit of worsening of the blepharoconjunctivitis. That usually happens within the first 3 to 6 months of treatment and then to settle within the first year of treatment. No follow-up blood tests are mandatory. If we need to update the vaccinations, we need to wait at least 4 weeks after a live vaccine to start Dupilumab. If a live vaccine is required during the treatment should be stopped 12 weeks and then have the live vaccine. No problems with non-live vaccines, okay? There are no consensus regarding the perioperative management, so it's more on a case-to-case basis between the dermatologist or the immunologist and the surgeon. Pregnancy category 1, but there is still a big question mark in terms of risk versus benefits, and not recommended during breastfeeding. And upadacitinib, more side effects with increased risks of infections, changes in the blood workup, such as lymphopenia, neutropenia. If the lymphopenia doesn't go below 500, sorry, the lymphopenia doesn't go below 500, and the neutropenia doesn't go below 1,000, that's not a problem. If the liver function tests do not go more than 3 times the upper limit of reference, that's not a problem. And the management of dyslipidemia, it's similar to a patient that is not on these kind of treatments. Remember to check about potential interactions, particularly clarithromycin and itraconazole that could be potentially prescribed at your level. Follow-up blood tests are essential for those reasons. We also need to update the vaccinations before starting the treatment. And if it's a live vaccine, similar to Dupilumab, we need to wait 4 weeks after we start the treatment. And if the treatment needs to be stopped for a live vaccine, we just need to stop it for 1 week. Regarding the operations, also remember to stop it just 1 week before, and it can be restarted 2 weeks after at the discretion of the surgeon. And this is pregnancy category test is not safe during breastfeeding. Have a couple of questions here. Is patch test, okay. We'll be able to have a copy of the slides. We are going to organize that together with a video. That's actually not a problem. We are going to also include the link of the survey regarding this talk. And is patch test done by dermatologists? It can be done by dermatologists and immunologists, because patch testing actually involves a bit of more work and requires more training. Not many specialists actually do it. I do it. So that's why sometimes I like to remember people that there is that kind of test available. But yeah, you might need to check with the immunologist or the dermatologist. Usually they might decide assessing the patient, then if the patient is to refer to the specialist that perform this kind of test. So yes, dermatologists can do patch testing. And remember, no issues with non-live vaccines with these 2 agents. Try to give priority to non-live vaccines if possible, particularly with the upadacitinib. And for example, now we have the non-live vaccine for zoster. And now that we're having more cases of Japanese encephalitis, there is actually an inactivated vaccine that can be used in these kind of patients. You can see the brands there. Something that also you can be aware at your level, if there is an acute infection, that is definitely recommended to stop the agent until the infection is fully resolved, and treat the infection as per the standard protocols. It doesn't require any particular changes in the scheme of antibiotics. Dupilumab can be administered in general practice. Sometimes it can be given by the nurses. If you want to have a little bit of extra training, the pharmaceutical company is happy to provide advice, videos, and sometimes even a face-to-face consultation. And obviously, I don't bite, we don't bite. If you have any questions or any comments, please do not hesitate to contact us. And we have one last question here. How easy is to access biologics? Actually, it's relatively easy in terms of if the patient fulfills the criteria and we do the right things. This has been actually a big game changer in terms of eczema management. We have seen patients that have been dealing with eczema for almost their whole life. And with these treatments, actually, I am going to say something that a patient told me that impacted me a lot when the patient said, I forgot how to sleep without scratching myself. So that definitely means that the treatment was a game changer for the patient. They function better at work, they look better, they feel more confident, they're really happy with the treatment. And then sometimes you might get the question, should I stop my treatment? Usually what I tell my patients is, imagine your life before, and with the studies that have been done so far, only 10 to 15% of patients might remain free of eczema if they stop the treatment within the first year. So that means that is a high rate of eczema recurrence if they stop the treatment. So that's a way for me to encourage them to continue them. Does St. George Dermatology Clinic take referrals from GPs? Yes, they do. I'm just going to show that later on the slides. Okay, with the infection, any infection in any system, what they have seen, particularly with upadacitinib, reactivation of hepatitis B, herpes simplex, and herpes zoster. skin infections like impetigo or even cellulitis, and pneumonia. Shingrix costs $300. Are there any ways for patients with eczema? Unfortunately not. Yes, cost can be an issue, and I understand that very well. So that's why we need to have a thorough discussion, and that's why I like to have my patients to get the vaccinations updated before they actually start the biologic agent. Do you advise contraceptives for young women? Is not mandatory, but particularly with paracetamol and the potential risks, I like to tell my young female patients to keep in mind to try to avoid pregnancy for that reason. Let me see, I think. Yep, okay. We're about to finish, guys. Thanks for hanging in there. Let me just go back here. Yep, and this is precisely how to access our department. The referral letter can be downloaded from this link. And sorry, I don't want to sound a little bit pedantic or a little bit arrogant, please, okay? Please try to include proper information so it can be adequately triaged. I'm going to put an example that is quite sad because I've seen quite a few referrals in that sense. I mean, like that, because I know that you guys can be really, really busy. But sometimes we get referrals that say, please address this patient that has a skin problem. So, you know, so in order to address the level of urgency, I'm not wanting you to make a very complicated diagnosis. But for example, if you think something that we have discussed in the talk, this is a patient that has eczema, not responding to topicals, potential candidate for biologics. Fine. This is a patient with eczema affecting more than 30% of the face. Fine. This is a patient with eczema affecting more than 30% of the body. Fine. This is a patient with eczema that he's really concerned about overuse of topical corticosteroids. Fine. Okay, so keep that in mind when we're putting that information with the referrals, okay? And you have the fax and the email that you can send the referrals to, so we can triage it and then contact the patient accordingly. Comment, a teenager with eczema on advancement that developed cataracts, can she go on biologicals? If the eczema is affecting beyond the eyelids with more than 30% of the face, or there is actually like a tiny bit, there is a subcategory, if the scores of eczema are categorized as severe, even if it doesn't fulfill the criteria surface, the patient can be a potential candidate for biologics. So yes, this is actually a good example of someone that could be referred for proper assessment. It can be a potential patient for biologics, yeah. What is the age limit to go on biologics? For Dupilumab, currently 12 years and older. However, TGA is going to extend it from 6 years old, although I think that is not still PBS covered yet. And upadacitinib, 18 years old, not approved for children yet. And in terms of for how long, it's very individual. For example, in the elderly, there are no issues in terms of upper age limit for Dupilumab. With upadacitinib, because of potential risk that has been seen in patients treated with different type of JAK inhibitors, we just need to be a bit more cautious in terms of screening the patient properly, cardiovascular, cancer screening, immunity, and then do a thorough conversation in terms of using this agent and then for how long. No worries.
I think that was the last comment there. Thank you so much for your time, Dr. Lara-Rivero.
No problem.
That was a very practical talk, and I think a lot of the GPs enjoyed that. So thank you, everybody, for attending and for participating tonight as well. Thanks.
Thank you so much. Thanks for the invitation. Good night.